Hey guys, it's Juliet. I haven't posted in a while, but I've definitely been busy. I thought I'd come on here and just make a video about what's been going on over the past year and what's been happening in my life. You probably don't know this about me, but I'm actually a resident physician. I'm in my last year of residency, and so I actually graduate at the end of June, which is really exciting. I'm an internal medicine resident and will be pursuing, starting cardiology fellowship in July of this year. But for the past 4 weeks, I've been working in our MICU, or medical ICU, where I've been taking care of COVID patients. At my residency, we do a lot of 30-hour calls, which means that you come in at 7 a.m. one day and you don't get to leave until about 11 a.m. the next day. And so you're there taking care of patients as a primary physician during that time. And if you're savvy with math, you'll tell me, Juliet, that's only 28 hours, and you're completely correct. The rule is a 24-hour shift plus 4 hours of additional time to finish up work that you need. And so we call it 38-hour call, even though we're there for 28 hours, because you're up and awake for more than 30 hours. But over the past 4 weeks, we've made some changes to our schedule where we were doing day and night shifts, but this week have transitioned back to 30-hour call. And so, given questions from my family and friends about what I do while taking care of COVID patients for 30 hours, I thought I'd make this video. And so basically, I'm at the VA right now in our MICU, where we house all of our COVID positive patients that need ICU level care. I come in around 7:30 in the morning. I put my scrubs on before I leave home, put a mask on, just a regular surgical mask, and then once I get to the hospital, we have a little check-in process where there are screeners every day. We get a new sticker every day to certify that we've passed the screeners. I head up to the MICU where I grab a different pair of scrubs, change into that, and those are the scrubs that I keep on for the entirety of my shift. I also change my shoes. I have a pair of shoes that I just leave in our little call room, so I'm not tracking any sort of virus or any other, any other pathogen in and out of the hospital to bring it home. So get there, get screened, change my scrubs, show up for rounds. Our MICU houses 8 patients at a time. There's only one resident physician on at a time. And we have a couple negative pressure rooms where we house our COVID positive patients. So there's an ante-room and a room that the patient is in. We'll talk about all of our patients just in front of our computers while doing our best to stay 6 feet apart, which is pretty difficult because we have 3 computers just in our unit, and they're definitely not 6 feet apart. We'll talk about all of them, go through the plan, and then our resident who had been on for the previous 30-hour shift than mine will get to go home. And then with my attending and my fellow, we'll start to go see patients. And so we'll usually round or go see and talk to our non-COVID positive patients first. I don't know why I just did air quotes on that. We'll see our non-COVID positive patients first, talk to them, give them the plan, and then we'll go see our COVID positive patients. And so, again, we'll change our scrubs into a new set. Then go into our ante-room and start gowning up. So you put on booties over your shoes, you put on a bonnet, a gown, gloves. We'll do our N95 masks and either goggles or a face shield, and then another bonnet on top of that. Go in, see the patient, talk to them, give them updates, see how they're doing if they're on a ventilator, check their vent settings, we'll likely draw blood gas to see what their oxygenation level is, and see if we can start weaning them down. Oftentimes these patients are on what we would call pressors, which are vasoactive medications that raise their blood pressure because they're often sick and their bodies aren't able to compensate as well. Because they're ventilated and have a tube in their throat, and so we call intubated, they're often also on sedating medications through the IV and also pain medications as well, which can drop their blood pressure too. And so we'll make sure to titrate all of those while we're in there, examine the patient, and then come out of the room. When we come out of the room, take off the booties while you're still in there. You clean your gloves, come out, start to de-gown, take your goggles, your mask, your bonnet off, wash your hands a couple times while doing that. Make sure that you drop your N95 into a plastic or a paper bag with your name on it so you know whose is whose. And then also wash your face shield or your goggles off before you leave the room. We call putting all that PPE on donning and taking it off doffing. And it takes about 5 to 10 minutes to do that each time, to come in and out of the room. And so it becomes a little bit of a process to do that. But we do that for each of our COVID positive patients and see how they're doing. And then additionally, because my hospital has restrictions on visitors, as I think most hospitals do at this point, I'll then give all the families of those patients a call and update them on how their loved ones are doing. We do have some iPads available for patients to FaceTime or Skype with their family, but unfortunately for our intubated patients, that's not really feasible, and so those family members really depend on our phone call to get updates on their family members. By the time I'm all done with that, it's probably been about 3 to 4 hours. It's 10:30 to 11, and I'll start to get to work on some of my other things that I need to do every shift. So we have to write progress notes every day. So I'll start working on those notes, talk to consultants, so folks who run different specialties that we need a little bit of assistance with, so GI or cardiologists who need to see patients in our ICU and we need their expertise. I'll give them a call, ask them questions, see if they can give us any advice or help us with certain procedures that patients may need done over the next day. By then it's about lunchtime. I'm not really allowed to leave the unit, and so luckily we have an assistant chief resident or one of my other co-residents not working in the ICU will bring me lunch from across the street. Our program is nice enough to provide us lunch every weekday, and so they'll often bring me lunch so I can eat. Sometimes I'll be able to eat right at noon and watch our educational conference at noon, and other times I'll be too busy taking care of patients to do that. And really throughout the afternoon, it can be a grab bag. There are some days where you're kind of just sitting there checking on your patients in the ICU, just eyeballing them, talking to them, making sure that they're doing okay. And then other days, it'll be pretty busy. So as the MICU resident, I hold a code pager. And so for every code blue in the hospital, so whenever someone's heart stops beating, I have to respond to that, run the code. So that often entails CPR, administering medications, leading the nurses and the other ancillary staff for what to do and creating a plan for those patients, and then oftentimes bringing those patients from the floor or the ED directly to my unit where they'll be under my care. And oftentimes those patients will need some sort of procedure done that I'll have to do. Oftentimes that is a line, so there's some very specialized lines that go in patients' necks or their groins and their wrists, so we can give them really strong medications that we can't run through a peripheral IV, and we'll often use an arterial line either in their wrists or their groin to monitor blood pressure as well. And then, in addition to responding to code blues, I'll also respond to RRTs, which are called rapid responses. And those are basically like a code blue, but before a patient's heart stops beating. So that's when a floor team or a nurse or someone recognizes that a patient is not doing well and that they need help and a higher level of care. And so very similarly to code blues, respond to that. We usually aren't doing CPR on those patients because they still have a palpable pulse and they have a heart rate, but they're definitely sick and will oftentimes, again, end up in my intensive care unit where I'm working. And so I'll get patients through those RRTs, those code blues, and then from the ED. And it's definitely been a struggle. I mean, it's hard. It was hard even before COVID happened. I've already done, I'm trying to think, before this year, before I was a senior internal medicine resident, I had done 14 weeks in our ICUs between our cardiology and our medical intensive care units. But this year I've done, I'm trying to think, so I did 2, 3, so this is my 9th week as a senior, so I've done over 20 weeks in our ICUs at this point. But before all this COVID stuff happened, it was very stressful to be in the ICU and take care of all these critically ill patients, but even more so since COVID started because of all these precautions with the donning and doffing that you have. And so I think some of the most stressful times for me are, one, when I'm seeing a COVID positive patient in my unit. I've already donned, I'm wearing all of my equipment, and I'm in there examining them, seeing what else we can do to help titrate their ventilator or some of those drips that they're on. But then that code pager that's always on the waistband of your scrubs going off, and realizing there's someone on the floor that really needs my help and doesn't have enough nursing care or medical staff to take care of them in this acute illness. So having to take off all of those precautions, carefully making sure that you're doing that safe so as not to infect yourself or anyone else, and then running over onto the floor to go see what's happening with that patient. And if that patient is also COVID positive or a PUI, that stands for person under investigation, so someone who may have COVID but hasn't tested positive yet necessarily, you have to do that same donning procedure. So let's say I'm in one of those COVID positive patient rooms and there's a code that goes off, I have to doff, run over, don again, and then go see that patient. And so just that period of time can be 15 minutes from when the code goes off and when I can actually see the patient in a safe manner. And so that's pretty stressful. We know that, time from loss of pulse to the initiation of compressions makes one of the biggest differences for folks who need CPR. And just that amount of time where it's not happening is stressful. And so we've also been working with our cardiology ICU, our CCU, to see if that CCU resident is able to respond to codes and RRTs as well, because they can often get there a little bit more quickly since they're not seeing COVID positive patients in their unit, unlike we are. And so that's pretty much what the rest of my day consists of. Like I was saying, there are days where, or afternoons where, between the hours of 1 p.m. and 10 p.m. nothing happens, and I've been there for 14 hours at that point. But there are other days where it's just nonstop and it just go, go, go. So it's really variable, but at some point in the afternoon, evening, I'll try and eat lunch. Our hospital does provide $10 of call money for every call that you're there. And so if I'm busy, I'll ask one of my other co-residents who are either working on the gen med floors or in the CCU to see if they could stop by, pick up some dinner for me. Sometimes my boyfriend will be really nice. he'll wait outside in the parking lot and drop off a meal, or I'll bring a dinner from home if I already know that it's going to be a particularly busy call. And then at some point after my dinner break, I should say dinner break because I normally just eat in front of my computer because I'm usually fielding calls from the emergency room or working on notes or talking to outside hospitals. I will likely admit another person or get another RT or another code. I feel like things tend to slow down around midnight, 12:30, so I've been there for, 7:30 to 12:30, about 17, 18 hours at that point. I'll make sure that I have ordered labs and chest x-rays for my patients in the ICU for the morning, make sure that my notes are updated, and then hopefully get a little bit of shut-eye. There is a call room that I'm able to use, which is just right inside our MICU unit, so I'll lay down in there. It just has a twin bed and a phone, no computer, and then an attached bathroom. I'll make sure that I bring my code pager and my list, and then hopefully remember to brush my teeth and get a drink of water if the day has been busy. And then either try and get a couple hours of sleep, or sometimes it happens where you're sleeping, you get a code, and then you're up for the rest of the night taking care of that really sick patient. The rest of the team arrives usually around 7:30-ish the next day. I give them a quick update on what happened, see if there's anyone else that they can help me put in a line in or do a procedure for, and then we'll round starting around 8 a.m. So again, I'll give the story to the entire team, which is our attending fellow and the new oncoming resident, and talk about what's been going on, work on calling some consultants. I'll usually drink a protein shake while this is all happening because I haven't had anything to eat for about 12 hours, even though I've been there for the whole time. And then work on signing out to that next resident who's going to do a 30-hour call. Before I leave, I'll make sure to change out of my hospital scrubs, put on a clean pair of scrubs, usually the scrubs that I just came in with the previous day, because doing all that laundry is a lot. And then I'll change back into my shoes that I wear to and from the hospital as well. The 30-hour calls are tough. My sleep schedules are crazy. I'll come home usually around 10-ish in the morning, sleep for a couple hours, try and be a normal person for the afternoon, eat dinner, watch TV, hang out with Andy, maybe Skype some friends or family, and then go to sleep and come back the next day at 7:30, work about a half day helping out, go home, and then come back the next day and do another 30-hour call. And that's very common for us. So we do about 4 weeks of 30-hour calls at a time. So every third day you do a 30-hour call. Your sleep schedule definitely gets wonky, but I understand why we do it. I think that, having the 30-hour call is helpful because you can really see how patients progress. You really get to know patients and their families very well in that 30-hour time span, and you know exactly what to follow up on. You have certain things in your mind that you want to see improve during your shift, and admitting someone that's really, really sick at the beginning of your shift and seeing them do a little bit better the next day and know that you helped them get through something is really rewarding. And so that is really nice. I have to admit that my last 30-hour call in our MICU is tomorrow, and so I'm a little bit excited about that, just from the sleep variability standpoint. But I will say that there is value. In the COVID era, I think it's just been incredibly more stressful because of all the precautions and then the worry about catching COVID yourself or bringing it home to a loved one also makes it more stressful. But the truth is that these patients need care, and someone has to be there to provide it for them. And at least having the support and the expertise, the nursing staff and the ancillary staff, who are all amazing in the ICU, help out, has really helped some of these patients, help some of them get better, and also help some of them die with, dignity in the way that they want. I think I'm gonna leave it at that for this video. Feel free to leave any comments or questions you have down below. I'll answer them as I'm able to. I can go into a little bit more detail if you guys want. But I'm also hoping to make some other videos, some about, being a young doctor, residency, in my upcoming fellowship, but also just talking about some other things that I'm interested, but feel free to let me know what you'd be interested in learning more about, and I'll try and make more videos when I have a little bit of time. Thanks. Bye.